Hello, welcome to AI Medical School. In this video, we are going to know about cholinergic drugs. Or you can say it cholinomimetic. Or parasympathomimetic drugs. But before we start, if you haven't subscribed to the channel, so subscribe to it and like the video, so let's start. These are drugs that produce actions similar to that of acetylcholine, either by directly interacting with cholinergic receptors or by increasing the availability of acetylcholine at these sites. So these are cholinergic agonists drugs, which divided into choline esters and alkaloids. We will discuss these drugs one by one. Actions depending on the type of receptor through which it is mediated. The peripheral actions of acetylcholine are classified as muscarinic or nicotinic. The central actions are not so classifiable and are described separately. Let's talk about muscarinic actions. The M2 muscarinic receptors are located in the heart. So what are the muscarinic action on the heart? Acetylcholine hyperpolarizes the SA nodal cells and decreases their rate of diastolic depolarization. As a result, the rate of impulse generation is reduced, bradycardia or even cardiac arrest may occur. At the AV node and his Purkinje fibers, the refractory period is increased and conduction is slowed. PR interval increases and partial to complete AV block may be produced. The force of atrial contraction is markedly reduced and RP of atrial fibers is abbreviated. Due to non-uniform vagal innervation, the intensity of the effect on RP and conduction of different atrial fibers varies, inducing inhomogeneity and predisposing to atrial fibrillation or flutter. Ventricular contractility is also decreased, but the effect is not marked. The cardiac muscarinic receptors are of the M2 subtype. Muscarinic action on blood vessels. All blood vessels are dilated, though only a few, skin of the face, neck, salivary glands, receive cholinergic innervation. Fall in BP and flushing, especially in the blush area, occurs. Muscarinic, M3, receptors are present on vascular endothelial cells. Vasodilatation is primarily mediated through the release of an endothelium-dependent relaxing factor, which is nitric oxide. The PLCIP3 deacylglycerol pathway activates endothelial nitric oxide synthesis through the calcium calmodulin mechanism. When the endothelium is damaged by disease, acetylcholine can diffuse to the vascular smooth muscle and cause vasoconstriction via M3 receptors located on their plasma membrane. Stimulation of cholinergic nerves to the penis causes erection by releasing nitric oxide and dilating cavernosal vessels through M3 receptors. However, this response is minimal with injected cholinomimetic drugs. Muscarinic action on smooth muscle. And most organs is contracted, mainly through M3 receptors. Tone and peristalsis in the gastrointestinal tract are increased and sphincters relax. Abdominal cramps and evacuation of bowel. Peristalsis in ureter is increased. The detrusor muscle contracts while the bladder trigone and sphincter relax, voiding the bladder. Bronchial muscles constrict, asthmatics are highly sensitive. Bronchospasm, dyspnea, precipitation of an attack of bronchial asthma. Muscarinic action on glands. Secretion from all parasympathetically innervated glands is increased via M3 and some M2 receptors, sweating, salivation, lacrimation, increased tracheobronchial and gastric secretion. The effect on pancreatic and intestinal glands is not marked. Secretion of milk and bile is not affected. Muscarinic action on eye. Contraction of circular muscle of the iris to miosis. Contraction of the ciliary muscle to spasm of accommodation, increased outflow facility, reduction in intraocular tension, especially in glaucomatous patients. Now let's talk about nicotinic actions. Nicotinic action on autonomic ganglia. Both sympathetic and parasympathetic ganglia are stimulated. This effect is manifested at higher doses. A high dose of acetylcholine given after atropine causes tachycardia and rise in BP due to stimulation of sympathetic ganglia and release of catecholamines. Nicotinic action on skeletal muscles. Iontophoretic application of acetylcholine to muscle end plate causes contraction of the fiber. Intraarterial injection of high dose can cause twitching and fasciculations, but IV injection is generally without any effect due to rapid hydrolysis of acetylcholine. Nicotinic action on CNS. Acetylcholine injected IV does not penetrate the blood-brain barrier, and no central effects are seen. However, direct injection into the brain produces an arousal response followed by depression. Cholinergic drugs which enter the brain produce complex behavioral and neurological effects. Interactions. Anticholinesterases potentiate acetylcholine markedly, methacholine to less extent, and have only additive action with Carbachol or Bethanechol, depending upon the role of cholinesterase in the termination of action of the particular cholinester. Atropine and its congeners competitively antagonize muscarinic actions. Adrenaline is a physiological antagonist. Use of cholinergic drugs. Cholinesters are rarely, if ever, clinically used. Acetylcholine is not used because of evanescent and non-selective action. Methacholine was occasionally used to terminate paroxysmal supraventricular tachycardia, but is obsolete now. Thanks for watching. I hope you liked the video and learned something. If you found this video helpful, so subscribe to the channel. Bye for now.